Welcome back to session 2. This one's all about the appropriate care in practice when it comes to medicines. I hope you're feeling well rested. I have a jam-packed session for you. We're going to be hearing from a bunch of different people. I'm personally really excited to hear from Dr. Kate Charlesworth, who's going to be talking about what we miss when we don't think about things like behaviour and lifestyle changes when it comes to avoiding prescribing medicines. But first up, we have Professor Paul Glasziou from Bond University talking about reducing waste in the use of medicines.
So good morning. It's my pleasure to kick off this second session with a presentation about overdiagnosis, overtreatment and low-value care as part of the session 2 on medicines and appropriate care in practice. I'm Paul Glasziou, and I'm a general practitioner by clinical background, but work a lot in low-value care. In particular, as you can see from the logo up the top right-hand side there, I work with a collaboration called the Wiser Care Healthcare Group, which is a multi-university collaboration. So I'm going to start with the big picture, first of all, of the problem going across healthcare. And then I'm going to focus down onto antibiotics in primary care and the impact that has on low-value care and on antibiotic stewardship and resistance. So let me begin with 3 numbers: 60, 30, 10. So this comes from a paper by Jeffrey Braithwaite and myself and Joanna Westbrook, which was part of a partnership collaboration on sustainability and healthcare. And we said that 60% of healthcare is evidence-based and high-quality care. About 30% of it appears to be low-value care, and perhaps 10% of it is even harmful care with the risk of adverse effects, for example. So those numbers are not exact. We don't know perfectly what those are, but they're probably in the ballpark. There's a lot of both micro evidence and macro evidence that's close to the truth. So I'm going to hone in on a couple of specific examples just to illustrate this. First of all, let's look at a review that was done by Ian Scott, who's a physician at the Princess Alexandra Hospital in Brisbane, and he looked at audits done in Australia that had 3 qualities. First of all, that they assessed inappropriate care. Second, that they ran some improvement intervention. And third, that they then reassessed it. So let's have a look at the first one up the top here, and you can see that for these coagulation tests in the intensive care unit, that roughly 65% was said to be inappropriate. Then they ran the improvement intervention and managed to get that down closer to 40%. And so that was a 23% reduction in inappropriate care. Whether all the yellow is inappropriate is very hard to know because there's a lot of grey zones in the area of inappropriate care. There's a lot of subjectivity in the decision making. But because we could see that 23% reduction, it probably was at least those 23% were low value care. So that was the general concept that Ian was after. This is having a look at all of the studies that he looked at. And overall, the range of values for the red component is between 10 and 49%. So roughly around that 30% figure that we were talking about. And it may be larger than that if we went somewhere into the yellow areas as well, but the 30% based on these seem reasonable. And I'll come back to some broader ones because obviously these were particular areas of concern. So one thing about those is that they're all local area studies, the individual hospitals or regions that were doing these studies, not scaled up. So one of the interesting questions is, can you scale up initiatives like this? Well, the answer is it's rarer, but it can be done. Okay, so let's have a look at an investigation at a national scale. This was a collaboration between the Behavioural Insights and Evaluation section in the Department of Health and that Wiser Healthcare Group that I mentioned at the start. And what we were looking at was trying to reduce the rates of imaging requests by Australian general practitioners for those who are in the higher band of image ordering. So this was a randomised trial of nearly 4,000 GPs randomised to different arms, including a control group. And they also looked at, in a factorial design, once versus twice giving of the feedback, and also looking at 2 different versions of the visual display. So overall, as you can see in the graph here, there was a substantial reduction in the numbers. There was about 47,000 fewer imaging tests, though in a relative reduction, it was pretty small, but highly statistically significant. And it was sustained as well. You can see from the first feedback to the second feedback that there's a sustaining of that difference between the control group and the 4 intervention groups combined. So that was a one-off at a national scale. I'm going to move on to look at the antibiotics, as I said, to try and look at what we might want to do on not just on a national scale, but also what could be done in a sustained way as well. So antibiotics are generally overused in primary care. This is a study we did a few years ago, where what we did was compare the GP's medical record. This is based on the Beach study data, where they get GPs to keep, for about a week, they keep a more detailed medical record and coding, so that it gives us more than the usual medical record to make decisions about the appropriateness of prescribing. And we compared that to the current antibiotic guidelines produced by Therapeutic Guidelines. And overall, we found about a 77% apparently unnecessary use of antibiotics. In particular, for acute bronchitis, you can see that second bar, it's all blue there. That's that the antibiotics in most cases of acute bronchitis are unnecessary. And obviously in community-acquired pneumonia, if we go 5 bars down, antibiotics are virtually always indicated. But overall, you get this pattern of about 3/4 of the antibiotics probably being unwarranted. Now, there are a lot of drivers of that, of course. It's hard to get down to 25% of what we currently prescribe, but I'll show you some data in Sweden in a moment. But could you make a change to this nationally? Well, that has been done. As an example, back in 2018, the chief medical officer, following a meeting that was held here at Bond, had a look at trying to reduce it by sending a letter, a feedback letter to the high prescribing GPs. And this was again a randomized trial to no letter is that first arm versus education only, education plus peer comparison with delayed prescribing, and peer comparison with a graph. So looking at those different potential interventions. And overall, there was about a 9% reduction. This is at 6 months, but there is actually a reasonable sustained one in the further long-term follow-up of this as well. So that's pretty good. You get a national reduction, but the problem is then trying to get down to your 75% reduction that I was talking about previously. This is one step in that right direction. So, and it's just one set of potential interventions as well, in particular looking at delayed prescribing and audit and feedback, but there are a number of interventions that have been proven to be effective in reducing antibiotic prescribing. So this is from a review that we did a number of years ago on what are the effective things that could be done. This isn't a full list of potential things, but it's just the summary things where we'd found trials that had other information that we required. So delayed prescribing, which is where you give the patient a prescription but say you probably don't need antibiotics, but here's the conditions under which you would want to use the antibiotics. And a lot of patients will then go away happy with the script but not use it because they've been forewarned that they don't need to use it. But other things that work are providing some extra testing for serious infection, like a procalcitonin or the C-reactive protein, shared decision-making processes, and the nudge poster. So the green is the effect, the red is the still using antibiotics. And I wanted to put this up in the context of there are multiple different ways that we may get people to reduce antibiotic prescribing. It's not just carrots and sticks, that there are other skills, resources, etc., that you may want to give people, that it's much more nuanced than just motivation, which the carrots and sticks relate to. There are other elements as well. So there are lots of other things we could do. The key problem with this, though, even though each of these individuals' interventions work, is trying to get GPs to use them. So in a second part of that article, we looked at what the population impact would be. That is looking at both that effect that we saw in the previous slide and multiplying that by the number of GPs within those trials who were offered entry into the trial, who then subsequently signed up. And again, we see delayed prescribing as the single most effective, but even it is diluted by the fact that only 19% of GPs who were offered a place in this trial actually decided to enrol in it. It may be possible to get these used at higher rates than this, but that's the challenge we face. And we saw in the CMO's letter where we had about a 9% reduction, that actually that's pretty similar to what we're seeing in the green bars here in a sort of one-off process. So a couple of questions that come out of this is, what is if we combine interventions? So in a collaboration that was done a few years ago, there was an attempt to combine several of these different interventions to see if they worked. This was not done in a controlled trial setting, but a randomized trial, but rather just to see what the impact of these would be in a pre-post setting. And it appeared to be effective, but a lot of unanswered questions remain that I think seriously need to be answered, which is, what are the best ways to combine these? Should we give them to people one at a time and teach each of them, or should we try and give people a choice amongst all of these and then gradually introduce one per GP? So there's lots of different ways we could do this, and we really need to know what the combined impact of them is, because it's a long-term problem that we're facing. So just to give you a picture of what could be done, the left-hand side here compares the antibiotic prescribing rates in 2014 of Australia versus at the top versus Sweden at the bottom in terms of the number of prescriptions of antibiotics per 1,000 people. And you can see Australia is much greater than Sweden. That wasn't always the case. We were actually much closer to Sweden back in the early 1990s. But what happened in Sweden was that they introduced this thing called the Strama program, which is a nationwide regular program that updates what it's doing every year to both monitor and to introduce interventions to try and reduce inappropriate antibiotic prescribing. And each year they get a little bit further down the track. It's a sort of 5 to 7% reduction per year, but sustain that for a couple of decades and you go from Australia's rate down to the Swedish rate. No one has yet found a magic bullet that will turn off the prescribing rates overnight. And what is clearly needed is a sustained program of implementation, but also a sustained program of research into implementation to find out about what the most effective combinations are, how to better deliver them, etc. So we need both those things, the implementation program and the research into it, if we're going to get down to something like Sweden. So that's an illustration of what can be done, that there's a promise of the ability to change, but that you need a sustained program of both implementation and research. Let's go back to the bigger picture for a moment. In that NHMRC Partnership Centre, one of the things that we were looking at was the overall causes of waste in the healthcare system. This comes from a model by Berwick in the US. And we looked at trying to work out what they were in Australia. So the areas were failures of delivery of healthcare, failures of coordination, over-treatment, administrative complexity, pricing failures, fraud and abuse. And for Australia, most of those were pretty modest. We do particularly well with administrative complexity. Pricing failure, there's a little bit within the PBS. We've got low rates of fraud and abuse. But over-treatment, which Berwick had estimated to be between 20 and 30%, we find about the same. But in doing so, that did not consider the issue of overdiagnosis. In Berwick's model, they looked at whether the treatment was appropriate given the diagnosis, but didn't look at whether that was an overdiagnosis, which we now know occurs at high frequencies with many conditions. To give you one example, with cancer, we have found roughly 20% of cancers are now overdiagnosed. That's particularly true for prostate cancer, but also surprisingly renal cancer, thyroid cancer, and to some degree the in situ melanomas as well. So there's a lot of potential here for a reduction in that 60-30-20 challenge, but it will take some sustained work to reduce that. So in conclusion, the 60-30-10 challenge is a challenge. It's clear that there's over-testing and over-treatment. It's quite common, though we don't know precisely in every area how much. But it's very importantly that change is possible, but that needs rigorous study of what works. It not only needs the rigorous study and these one-off programs, but it needs a sustained program in each of those major areas as well. So thank you very much for your attention. Hope you got some things out of the presentation. I'll look forward to the panel discussion at the end of this session. Thank you.
Thank you so much for those insights, Paul. And to build on those now, we have Associate Professor Liz Marles of the Australian Commission on Safety and Quality in Healthcare. She's also a general practitioner at Hornsby Brooklyn GP unit and is going to be talking about harnessing stewardship when it comes to quality use of medicines for both sustainability and better patient outcomes.
My name is Liz Marles. I'm the Clinical Director for Primary Care at the Commission for Safety and Quality, and I'm also a GP in Sydney at the Hornsby Brooklyn General Practice Unit. So I'm talking about a favourite topic of mine today. So this is going to be about harnessing medicine stewardship for sustainability. And we do have a challenge. So despite all the resourcefulness and efforts over the past 30 years, the care provided in the health system has flatlined. So care in line with guidelines hovers at around 60%, and that's been shown in large empirical studies of multiple conditions in adults and children in USA, England and Australia. Some 30% of care is waste, duplication or low value, and it's very difficult to justify considerable expenditure in this space. And then 10% of care is actually harmful. And that's where you have iatrogenic harm or adverse events that affect the population. Addressing the issue of low value care triggers a convergence of benefits for the individual, for the community and for the planet. This is clearly demonstrated when antibiotics are used more thoughtfully and appropriately. We have less resistance, more effectiveness and less waste. So I'm just going to take a case study here where we look at the overuse of proton pump inhibitors. So these drugs, as we know, they're very effective and widely used medications for treating gastroesophageal reflux and peptic ulcer disease. But there is evidence of inappropriate prescribing, the set and forget, resulting in the overuse of PPIs with a very large number of patients using high doses over a long period of time. So let's talk about Hugo. So this is Hugo here in the picture. He's suffering from gastroesophageal reflux disease, and probably because he's drinking a little bit more than he should. So to deal with the effects of his reflux, he started taking Nexium. And in fact, he's probably been taking it for about 10 years now. He is one of thousands of people who are overusing their proton pump inhibitors, and it's not food for the planet, and it's also not good for Hugo. It does put him, although it's a small risk, it does actually put him at an increased risk of GI infection, things like Clostridium difficile, community-acquired pneumonia, osteoporotic fractures, interstitial nephritis, and nutritional deficiencies. It adds to the economic burdens in the health system because there's less money available to spend on other priorities. And the processes required to make the drug, package the drug, and then ship it to Hugo's local chemist are a significant contributor to climate change. And it doesn't have to be this way. So in a world where healthcare systems are facing numerous challenges, it's crucial to recognise that the decisions that we make have an impact on the well-being of individuals, communities, and the planet as a whole. So our approach to stewardship, which is what we do to supervise and take care of our patients, has the potential to reduce that unacceptably high level of low-value care and, as a result, to ensure better outcomes for patients, a fairer and more robust health system for all, and improvements in the burdens that we place on the environment, particularly through pharmaceuticals. So today I'm going to be talking about how medicine stewardship, quality use of medicines, and appropriate care can contribute to sustainability and better outcomes. So medicine stewardship refers to the responsible and ethical management of medications throughout their life cycle. This begins with the development of a drug, followed by the manufacturing, distribution, prescribing, which I'm going to particularly talk about, dispensing and disposal of medicines. And by adopting a comprehensive approach to medicine stewardship, we can minimise waste, reduce environmental impact, and optimise the use of resources. One of the key elements of medicine stewardship is the quality use of medicines, or QUM as we know it. So the National Medicines Policy underpins people's access to and wise use of medicines. Quality use of medicines is one of the central objectives of Australia's National Medicines Policy, and it focuses on selecting management options wisely, choosing suitable medicines if a medicine is considered necessary, and using medicines safely and effectively. And we need to be aware that when we talk about medicines, we're actually talking about prescription, non-prescription, and complementary medicines. So quality use of medicines is about ensuring that patients receive the right medication at the right dose for the right duration and with the right information and support. And by promoting quality use of medicines, we can enhance patient safety, improve treatment outcomes, and reduce the burdens on the healthcare system. So as a practitioner, my focus is on providing the most appropriate care for my individual patient. And in doing this, I can achieve the dual goals of sustainability and better health outcomes. Appropriate care involves tailoring your healthcare interventions to the individual patient's needs, their preferences, and their circumstances. It recognises that every patient is unique and requires personalised care. And by providing appropriate care, we can avoid unnecessary treatments, reduce healthcare costs, and improve patient satisfaction and well-being. 3 questions to ask yourself when you actually have a patient that encompasses all of these things. First of all, what are the management options? Is the medicine actually necessary? And how can it be used safely and effectively? And by doing this, we know that we're going to deliver better outcomes for individuals, for the community as a whole, and for the planet. The Commission has developed a number of resources, and in particular our clinical care standards, to support appropriate care. Stewardship has been adopted in many of these therapeutic domains. So antimicrobial stewardship is mandated in hospitals and is now being adopted by community providers, including residential aged care facilities. Similar programs have subsequently targeted opioid analgesics, anticoagulants, and antipsychotics, with an interest in other therapeutic areas as well. So with antimicrobial stewardship, these programs emerged in the late 1990s, and they're probably the earliest coordinated programs to steward the use of a specific class of high-risk medicines. Many studies have demonstrated consistent evidence that antimicrobial stewardship activities have been shown to reduce unnecessary and inappropriate use of antimicrobials, reduce patient morbidity and mortality, and actually reduce bacterial resistance rates and healthcare costs. Another growing area of medicine stewardship is opioid stewardship. And opioids, while they're effective in managing pain, they carry a significant risk of addiction and overdose. And this has been supported in the opioid analgesic stewardship in acute pain clinical care standard developed by the Commission, particularly targeting opioid prescribing in emergency departments and for post-operative pain. Opioid stewardship programs focus on promoting safe and responsible opioid prescribing, monitoring patients for sign of misuse, and providing education on the risks and alternatives to opioids. The Commission has had the Atlas of Clinical Variation, which has been in place now since 2016. And for some of these things that the Commission looks at, we have developed a time series where we've collected data over that period from 2016-17 to 2020-21. 2021. And if we look at opioid medicines dispensing in that period, we can see that it has fallen nationally and in all states of territory over that period of time. In terms of the national trends, there's actually been an 18% decrease in opioid medicines dispensing rate, and that is the number of prescriptions per 100,000 people. The biggest decline occurred in 2020-2021. There was also a 14% decrease in the number of people per 100,000 who were dispensed at least one PBS prescription for an opioid medicine. On the right of the slide, we can see that there's been a 30% decrease in the overall volume of opioid medicines supplied on any given day, as measured by the Australian rate of defined daily doses dispensed per 1,000 people per day. And I think we can see there that although there is variation between the states, across that period of time, in every jurisdiction, we've seen a fall over those time series. What we do see, particularly if we look at the left, is that there's still variation in the magnitude of, there is still variation occurring between jurisdictions in what is actually prescribed. And we know that there's about 5 times higher rates of prescribing in the highest area to the lowest area. So anticoagulation stewardship programs, they aim to prevent adverse patient outcomes due to over or under anticoagulation. We know that venous thromboembolism is a common preventable cause for in-hospital death, and it accounts for approximately 7% of all deaths in Australian hospitals. And that's commissioned data from 2020. Interventions can include implementing anticoagulation or thromboprophylaxis guidelines, education for prescribers and patients to optimise the use of anticoagulants or reversal agents, and oversight of the management of heparin-induced thrombocytopenia. One Victorian hospital, which it was the Alfred, they actually described a 33% reduction in hospital-acquired venous thromboembolism at the same time as they achieved a 20% reduction in anticoagulation-related bleeds after the program was implemented. So in 2019, quality use of medicines and medicine safety was named Australia's 10th National Health Priority. The Commission was tasked with drafting the National Baseline Report to inform new best practice models, new national standards and better medication management. Phase 1 of this has been focused on aged care and issues of polypharmacy use of antipsychotic medicines and transitions of care. Phase 2 will be looking at investigating the broader issues of quality use of medicines and medicine safety, as well as issues of medication safety during transitions of care. Quality use of medicines is crucial for achieving better health outcomes. It's supported by evidence-based prescribing, education of both healthcare professionals and patients about the risks and benefits of medications, and fostering shared decision-making. In conclusion, medicine stewardship, quality use of medicines, and a focus on appropriate care are essential components of sustainable healthcare. By adopting these practices, we can minimise waste, reduce environmental impact, optimise treatment outcomes, and improve the efficiency of healthcare delivery. It is our responsibility as healthcare professionals, policymakers, and individuals to embrace these principles and work together towards a sustainable future. Let's strive for a world where every patient receives the right medication at the right time and in the right way. Thank you.
Thanks so much, Liz. Those insights on sustainability are so important. And when it comes to medicines, sometimes the trick is to not prescribe them at all. So what do we miss when we forget to, or maybe don't think to prescribe things like behaviour change or social prescribing? Well, we're about to find out with Dr. Kate Charlesworth. She's the Senior Advisor for the Climate Risk and Net Zero Unit at the UNSW Ministry of Health. Take it away, Kate.
Oh, hello, I'm Kate Charlesworth. I'm a public health physician by background and I lead the Climate Risk and Net Zero team at New South Wales Health. And it's my pleasure today to talk about the future of medicines and in particular how the health and environmental benefits of good medicine stewardship. So firstly, I'd just like to acknowledge that I'm on Camaragal land today, and in particular to note that Aboriginal people have been tremendous stewards of this land for more than 60,000 years, and that the themes of stewardship and caring for country are particularly relevant to what I'll be talking about today. So for me today, there are three key messages. Okay? The first one is that climate change is a health issue. Certainly it's an environmental issue, it's a social issue, it's an economic issue, but fundamentally this is about health and about care. Okay? And if you look at now the escalating climate risks, for us it becomes very clear that we cannot continue to provide a quality health service unless we respond to climate risk. Okay? And then secondly, leading on from that, how do you reduce carbon emissions in healthcare? And in particular, what are the carbon hotspots of many things, but including of medicines? And then lastly, of course, and the key message here, the quality use of medicines is so well aligned with our net zero transition. So there is now overwhelming scientific evidence that climate change is supercharging the climate. It's making more frequent and more severe storms, floods, droughts, extreme heat, and bushfires. And if you look at what's happened in the Northern Hemisphere over the last few months, and indeed what's projected for Australia for this summer and future summers, it is very clear that we cannot continue to provide quality healthcare unless we respond to climate risk. This is the really critical point. Okay? Climate change is not going to be a linear process. Okay? The Earth is not a line. It's a system. It's a series of interconnected ecosystems. Okay? And we have now left this so late. Okay? We have ignored scientists' warnings for decades that we are now in danger of hitting tipping points. If you hit tipping points, and you're looking at runaway climate change. Okay? So that's why the IPCC has said that we need to rapidly reduce emissions this decade, that is by 2030, okay, to avoid that catastrophic climate breakdown. Okay. And so every sector has to decarbonise: energy, transport, agriculture, and the health system has a particular responsibility to do so, because currently we're part of the problem. Okay. We use huge amounts of resources. We produce vast amounts of waste. We still use fossil fuel-based energy. We have an enormous carbon footprint. Globally, if the health system were a country, it would be the 5th biggest polluter on the planet. Okay. And in Australia, the health system's carbon footprint is about 7% of our national emissions. Okay. So we have a responsibility to decarbonise. I think that's a pretty strong environmental case for us to do so. But for those of us in the health system, there are now a growing range of requirements for us to decarbonise. It is, of course, now the law. Under the Climate Change Act of 2022, passed by the Australian Government last year, we have to reduce emissions by 43% by 2030. And there is a new National Climate Health Team unit set up within the Federal Department of Health. We're working on our new National Health and Climate Strategy, which is due to be released by the end of the year. And the decarbonisation of the health system is one focus area for that strategy. There are similarly a range of jurisdictional targets. In my state of New South Wales, we have to reduce emissions by 50% by 2030. Regulatory, a number of examples there, but of note, the Australian Commission on Safety and Quality in Healthcare is developing a sustainable healthcare module that will be optional in the first instance, with a view to that becoming a mandatory part of hospital and healthcare accreditation standards. Health, I think I've covered. Financial. It is a myth that sustainability always costs more. Okay? In fact, some of our leading local health districts in New South Wales saved nearly $1 million last year from their sustainability program. And particularly in terms of medicines management and appropriate medicines management, if we are reducing the harms and risks of things like polypharmacy, if we're reducing the number of patients coming into hospital with medication-related harms, then there would be substantial financial savings from that work as well. And then finally, this is an issue that many of our staff care deeply about, and that increasingly our community expects us to act on. There's a clear task then for us to decarbonise the health system. Okay? To do that, you better first understand what your baseline carbon footprint is and what the carbon hotspots are in healthcare. So this is a paper that was published in 2018. This is the carbon footprint of the Australian health system. Okay? As you can see there, it's hospitals, which are the big emitters in the blue sections, but that dark green section is pharmaceuticals. Okay? Nearly 20% of the health system's carbon footprint in this country is from pharmaceuticals. In New South Wales Health, we have been doing a lot of carbon footprinting of hospitals and local health districts this year. So this is more recent data. This is for Nepean Hospital, which is a large metropolitan tertiary hospital in Sydney. As you can see there at the top, pharmaceuticals and chemicals, 9% of that hospital's carbon footprint. And indeed, when we look at the breakdown and what are the top carbon hotspots for us in hospital, pharmaceuticals are number 3. Why is that? Thinking is that pharmaceuticals have a very long supply chain. There's a whole process involved in developing and manufacturing pharmaceuticals, from the research and development, manufacture, distribution, transport, packaging, waste, and so on. Pharmaceuticals are also very chemical intensive to manufacture, which is carbon intensive. Okay? So for those reasons, pharmaceuticals are a large carbon hotspot and therefore a particular priority for health systems in terms of their decarbonisation efforts. Okay, so what do you do about that? How do you decarbonise our pharmaceutical footprint whilst improving the quality use of medicines? It turns out the two are pretty closely interlinked. So I think this is the most important slide in my presentation. This is our approach to medicine stewardship. This is the way that we optimise health and environmental benefits from medicines management. So there are 3 key approaches there. And the first one is appropriate prescribing. And the very first question under appropriate prescribing is, well, do I need to prescribe a medicine? Is a medicine the safest and most effective treatment option in this case? Okay. And then we get into sort of medication reviews and deprescribing where appropriate. So that's the first action. Okay. Then the second one is optimising medicine use. And that's saying, okay, where it is appropriate to prescribe a medicine, how do we optimise that medicine? How do we get the best out of it for that patient? And then the last action area is around product stewardship. And that means taking responsibility for the whole life cycle of that medicine or pharmaceutical. So I'd just like to provide some, sort of to illustrate that point, provide some examples. So on our first point, appropriate prescribing. The number one question, is a medicine the safest and most effective treatment in this case? Okay? Because there is growing evidence in healthcare and in medicine that in many areas, non-pharmacological treatments are safer and more effective in terms of treatment. So for this example, it's looking at mental health outcomes, but there are similar examples in sports medicine, orthopedics, and many other areas. Okay? In this case, exercise has been found to be safe, highly effective, and also low cost, almost virtually no cost, and low carbon treatment option. Just to draw down on the exercise benefits of physically active people, as you can see here from Public Health England, those active people have substantially lower health risks across a whole range of chronic disease outcomes. As you can see there, from cognitive decline, so that's dementias, type 2 diabetes, hypertension, mental health outcomes, some cancers, coronary heart disease, and stroke. So if exercise were a pill, it would be regarded as a miracle cure, and the pharmaceutical companies would be fighting amongst themselves to bottle it and market it. Okay? So this is just one example. I've talked about exercise here, but of course there are a number of other examples. You could talk about healthy eating and diet. You could talk about sleep management, stress reduction. A lot of these lifestyle medicine type treatment options are being shown to be safe, very effective, and of course, as we've discussed, low carbon and low cost. So that's why it's the first consideration. Okay? Then the next 2 sort of actions there are about medication reviews and deprescribing. Okay? So as you would be aware, as you can see here, we have a substantial problem with polypharmacy. 9 out of 10 Australians in aged care take 5 or more medications each day. And in fact, 2/3 of Australians in aged care take 10 or more medications every day. That's hyperpolypharmacy. And I was speaking with an ED doctor colleague the other day, and he said he saw a patient in ED recently who was on 27 medications. 27. Okay? We know that polypharmacy is associated with an increased risk of functional decline and of medication-related harms. Okay? And that 250,000 Australians every year are admitted to hospital with a medication-related issue, okay? Many of which are preventable. So that's why it's particular action here. Obviously, deprescribing is the discontinuing a medication for which the risks of harm outweigh the benefits. Okay? Important that deprescribing is done appropriately. As you can see here, a number of resources now and guidelines about appropriate deprescribing. Okay. And this is not specific to pharmaceuticals, but I think it makes a really important point here. This is a paper that we published in the Medical Journal of Australia last year. Okay. It shows on the left a simplified version of the carbon footprint of the Australian health system. So as you can see, there are only about 20% is directly buildings, electricity and gas. About 80% is related to clinical care. Okay. Then it extrapolates that over to the right, the bar chart on the right, where you can see there from the literature, 10% of care is harmful. Okay. So harmful care is where a patient goes for an investigation or a procedure or is prescribed a medicine which is unnecessary, and then they have a poor outcome from that treatment or medicine or investigation. Okay. That's harmful care. 30% of care is low value care, and then as you can see there, 60% of care is effective care. So the point that we're making there is that if you add together the 2 and the 8, more than 10 million tonnes of carbon is currently being wasted on harmful or low value care. Okay? So that is why this is the first and most important, the first approach is appropriate prescribing. Okay? Then the second set of actions around optimising medicine use. That is saying, okay, where it is appropriate to prescribe a medicine, how do we optimise that medicine? How do we get the best outcome for the patient from the use of that medicine? And a lot of that is around patient education, making sure that our patients understand the correct dosing, the timing, and so on. And that, for things like inhaler use, they have a good technique. That sort of comes into that. And then there's also stock management, of course, as well. How can we best utilise our stock? Lots of IT solutions now around tracking it and better management of stock. And other solutions. For example, in some hospitals now, staff get together once a week or once a month, bring all their nearly expired stock and exchange it between wards so that much less is wasted. So all those sorts of initiatives come under their optimising medicine use. And then we move on to the third area, which is product stewardship. And this is about taking responsibility over the whole life cycle of the medicine. So from the sort of research and development, the manufacture, the distribution, the transport, the packaging, the waste. Who's taking responsibility for that over its whole life cycle? And the important things here are about supplier engagement. So starting to have discussions with our suppliers, with pharmaceutical companies about reducing carbon footprint of medicines, and factoring that into procurement policies as well. How can we put into our procurement criteria that we want to see less packaging, that we want to see less travel emissions from the delivery of pharmaceuticals, that we want pharmaceutical companies to be reducing their carbon footprint. So factoring those things into our policies. And then we get to the point of carbon disclosure. Actually, pharma companies are required to disclose what is the carbon cost of this product, and then we take that into consideration when we're deciding which medicines to buy. Okay? Carbon disclosure. And then the final point there is recycling, which is obviously important as well. We're always going to have some pharmaceutical waste. How do we appropriately recycle that? And importantly, looking for circular economy solutions. So recycling that into new products. This is just one example, Pharmacycle, a new company, which is taking, for example, blister packs, separating those out into aluminium and the plastic, and then recycling those two streams into new products. good solution, currently quite expensive. So then the question becomes who is responsible for those blister packs and who's going to pay for it. Just to give a couple of examples to finish from New South Wales Health, recognising the really important role of clinicians in decarbonising our health system, we have a Net Zero Leads program under which we fund 10 of our staff 1 day a week each to lead on net zero projects in their service or specialty. And we're focusing on our known carbon hotspots. So just a couple of examples in terms of medications. We actually have 2 net zero anaesthetists. And that's because anaesthetic gases is about 5% of a hospital's carbon footprint. As you can see there, one of the main culprits is desflurane, highly polluting anaesthetic gas, which has a global warming potential 2,500 times that of CO2. Okay. So we are now tracking, New South Wales Health, now tracking our desflurane use. As you can see there, we've gone from more than 4,000 tonnes of carbon from DES in 2019, down now to about 700 tonnes of carbon. Okay. So our anaesthetists, having taken on the environment, having understood, I guess, the environmental impact of desflurane, are to be congratulated for shifting away from desflurane towards clinically equivalent alternatives and have been responsible for the significant reduction in the carbon footprint of DES. And WA is to be congratulated. They've actually taken desflurane off their statewide formulary. So you won't be able to even get desflurane now in WA. And we also have, of course, the Net Zero Pharmacy Lead, recognising the carbon hotspot that is pharmaceuticals. Derek Kay, who's the Director of Pharmacy at Bathurst Hospital, and is working on several projects around appropriate segregation and management of pharmaceutical waste. Finally, just to finish, we'd like to finish with these twin messages of risk and opportunity. I think the risk part there is pretty well summed up by John Kerry, but also that this is a tremendous opportunity for us. As set out on that cartoon, on this cartoon, so many climate actions would have substantial public health benefits. It would mean cleaner air, healthier diets, greener and cooler cities, more connected communities, and so on. And in medicines management in particular, this is another win-win situation. We can improve health outcomes, we can reduce the harms and risks and costs of medicines use and reduce the carbon footprint of medicines use at the same time. But of course, the climate emergency now adds a real urgency to this work. So we really do need to get our skates on. Thank you.
Thank you, Kate. And to build on and expand on some of those topics, we're now going to delve into a conversation about what we can do to drive appropriate prescribing in practice. And I'm joined by 3 of Australia's best on this, Alexandra Barrett, Professor of Public Health at the University of Sydney, Tim Perry, Consultant Pharmacist Lead, and Dr. Brett Montgomery, joining remotely from Western Australia, who's a general practitioner and is in the School of Medicine at the University of Western Australia. Thanks for joining me, team.
Pleasure.
Nice
Thanks for having us.
So let's get started in, I suppose, when we're thinking about appropriate prescribing, the first step is when can we not prescribe? Talk to me, Alex, about what you've done in the realm of over-testing and over-diagnosis. We heard a little bit about that from Kate just now.
Yeah, thanks. It's a really good question. And I think it's really helpful to step back and think, what are the drivers of over-prescribing? Because it doesn't come out of nowhere. And 2 of the biggest drivers we know from the evidence are over-testing and over-diagnosis. So if I just give an example of each, in terms of testing, a good example is vitamin D testing. We have data going back a couple of decades, and we know that the rate of vitamin D testing has increased more than 200-fold over the last 20 years. We looked at some data in 2020, and there were 4.4 million vitamin D tests done in Australia that year, which is quite remarkable in a land that is bathed in sunshine, which is partly where you get vitamin D. That's 1 for every 6 adults. And so you can see that with that amount of testing, there is the risk of over-prescribing because tests lead to more tests, to monitoring, and to taking supplements. Interestingly, some colleagues did some work and they looked at a big sample of patient records, 1.5 million records, and they looked to see amongst the people who had vitamin D tests, what proportion of them were clinically indicated, and they said that 76% of them, they could find no clinical justification for it. So that's an awful lot of vitamin D tests that we think are probably over-testing and therefore leading to the risk of over-prescribing. The other driver that I mentioned is overdiagnosis. A good example that we've looked into is ADHD diagnosis in children. We know globally the rates of diagnosis of ADHD have been going up for the last few decades, and we see that in Australian data too. We're able to work out that a proportion, like a good proportion, around about 25% of those children who are being diagnosed actually have hyperactivity inattentive behaviours in the normal range. Mm-hmm. So while the diagnosis rates are going up, the prevalence of hyperactivity inattentive behaviours has actually been flat, it's been stable. So it suggests that what's going on is more about overdiagnosing, and therefore, rather than children's behaviour changing, and therefore there's a risk of over-prescribing in that area as well. And in fact, that's consistent with the data from the Healthcare Atlas of Variation that shows about a 30% increase in ADHD prescriptions for young people in recent years. So there's two good examples of where we think overprescribing is coming from.
They're two, I mean, obviously important, but is it so bad if someone's on a vitamin D supplement or maybe is medicated for ADHD compared to other, maybe overdiagnosing something like cancer where there's a big cascade of medical interventions that come after that?
So that's a really good question. Let me take it one step at a time. So to come to ADHD, I think if I was a parent of a child who might have ADHD, I would not want to see them diagnosed and treated without good, high-quality evidence that that's going to be beneficial. And surprisingly, we don't have that good long-term high-quality evidence. We recently did an observational study, but it's called an emulated target trial design to try to come as close as possible to a clinical trial. And it actually suggested harm to the children who were diagnosed and treated rather than benefit over the longer term. So, I'm not saying we should stop diagnosing and treating children with ADHD, but I am suggesting that particularly for those children who are at the mild end of the spectrum, we really need some better data, because obviously we don't want to be harming children, putting them at risk of stigma, etc., feeling awkward with their peers, unless we know that it's really going to be beneficial for them.
Mm. So Tim, as your role in the pharmacy side of things, how does these sort of patterns that Alex is talking about present to you?
I think it's very interesting. I often see patients who are being simple conditions like high blood pressure, where I have patients who will be diagnosed with high blood pressure where we don't really have much data on their blood pressure. So we're often starting treatment where perhaps we could have been talking to the patient about what else they could do to manage their blood pressure. So I see that a bit, and I think that potentially medicalising what could be a range of normal behaviour or normal variations. So I see that a bit. I mainly work as a consultant in general practice, so I'm not working in pharmacy dispensing medicines. So I'm looking at patients who have either been diagnosed with a condition or are at risk of a condition, and my role is to work with the patient, the doctor, the team to help them better manage that. So if we can do anything to help the patient, empower the patient to take charge of what they can do, what they can control, that helps to reduce the risk of us starting treatment where it may not really be needed, or minimising the treatment.
And in terms of appropriate prescribing and case studies, Brett, you've done a lot of work into asthma treatment. Can you talk us through what you've done there?
So I'm interested in respiratory inhalers and sort of green inhalers. And a few years ago, it was pointed out to me about the propellant gases inside mid-dose inhalers being bad for the environment, and I got interested in that. I think there's growing awareness of that, and people have heard about that. And you might think the answer is just moving to other inhalers, but when you step back and look at the bigger picture of the environmental impacts of respiratory inhaler prescribing, I think we do need to start, as Alex and Tim have been saying, at the point of diagnosis. if you look, it seems like in evidence from Canada and Australia, like maybe about half of the people who have been told they have COPD, chronic obstructive pulmonary disease, maybe don't if you do spirometry, and just points to the importance of getting the diagnosis right so that we're not over-prescribing and causing waste and also needless environmental impact, and breaking down some of the barriers to getting spirometry happening, barriers which have been existing for some years, money barriers, confidence barriers, knowledge barriers, and since COVID, also even bigger barriers to do with it getting harder to do spirometry. I just think it does start there with getting diagnoses right, rather than just thinking about different inhalers.
There does seem to be a tension here, Alex. I'd love to get your thoughts on it, between having enough data to make a good prescribing choice and not over-testing. How do you walk that line?
Oh, dear. I think the answer is with evidence and with empathy. So I prefer to actually talk about having evidence-based decisions. And I think we all, feel that if we look at the evidence and it gives us a good guide on when it's worth testing, then we're less likely to run into troubles down the track. But I also think that it's not black and white. And there are situations when you might do testing outside of an evidence-based guideline because for whatever reason, it's really important to that patient. So for me, it's a kind of confluence of both evidence and having the best quality evidence. I think that's really important, and there are plenty of areas in healthcare where we really could do with some better evidence, but it needs to be put, and that's the job of the clinician, sorry guys, to bring that to your individual patient, and depending on their clinical circumstances and their personal preferences and where they are in life, to make the best decision with them.
Brett, how do you do that in your practice?
I absolutely second that principle. And I do think my impression is that evidence has been better at studying treatments, particularly treatments for common conditions, cardiovascular medicine. We've got lots of big trials and so on, and we know versus placebo, how likely is a given drug to help. A lot murkier when you come to rational investigation, rational testing. I think a lot of the guidelines are based on expert opinion, having looked at an evidence base that is often rather thin. Like one place where we could be more restrained in our testing is, people presenting with fatigue in general practice. That's a very common presentation. Often there's not going to be a medical cause found for that. And there are good guidelines which articulate sort of a standard of practice saying, look for red flags. If there aren't red flags to suggest something possibly nasty lurking here, it can be quite appropriate to defer. I don't think anyone's ever done a great big randomized controlled trial of that as a strategy, delaying versus doing the testing early and finding out what happens. I think those recommendations sound fine, but to suggest that they're based on high quality evidence, I think the evidence is not there. And when the evidence is more slender than we would like it to be, then I think we should always prioritise patients' values and views, but they probably weigh higher in the equation when the evidence is a little more slender.
So as part of the lead up to this conference and then throughout the conference, we've been asking you to submit your questions, which you can still do by entering them in the box below. And one of the questions that was submitted ahead of time, I might actually come to you first on this, Tim. Someone's written, most people visiting the doctor are expecting to receive a treatment, which usually involves a prescription. How do we change that perception that a drug is going to fix the problem and shift attention to the importance of non-pharmacological strategies? This is a pet topic of yours, I know.
It's a pet topic, but I actually don't know the answer. Sorry. it's such a big challenge to, we look at the therapeutic guidelines, which we have list of strategies to use for managing a condition, and for most chronic conditions, step number one is lifestyle intervention. It's looking at sleep, diet, exercise, risky substances. That's the starting point for just COPD, hypertension, cardiovascular disease. Lifestyle interventions is the main thing, but I feel like we often gloss over that a little bit. We say, go and do some exercise, change your diet and come back in 6 months, and if that didn't work, we'll start some medication. And it's really hard. So we need our clinicians to be thinking more about how do we help that patient, how do we engage the patient in their own health, and how do we get the patient to be thinking about that as well. So I keep thinking about actually the Life Be In It campaign that,
I should have worn my Life Be In It t-shirt.
Norm getting off the lounge and getting out and getting some fresh air. We all need to be thinking like that. What can we do about our health to improve our health? And we need our clinicians to be reminding us about those strategies. So we need people like me funded into practice to be able to talk to people. We need advertising campaign. We need everyone on board with the idea. So that's the solution. Everyone.
Can I add?
Yeah, please.
Yeah. It's a really fascinating area, which I've just been looking at the evidence on some of that area recently. And it's an area where the evidence is not that thin, to my surprise, nature prescribing. So there's actually a large systematic review that's just been published of 92 controlled studies looking at nature prescribing. So this is either by the GP or by a social worker, giving people a prescription to spend time in nature, which might be a park or can be anywhere that's outside in nature. And they actually showed quite good improvements in depression scores, anxiety scores, reduction in blood pressure, and increase in step counts. So I think there's one thing that we happily do have some evidence for.
And I suppose in terms of like appropriate prescribing, if you prescribe a medication, you can make a money. There's a profit margin attached to that for whoever's selling that medication, or there's a Medicare item number for whatever the prescription is. How do you build something like nature prescribing into the system that we've currently got?
Yeah, well, that's a really interesting question. So we have, we're blessed in Australia. We have the PBAC which makes decisions for the pharmaceutical benefit scheme and the equivalent thing for Medicare. So I guess that's a possibility, is to put that into health technology assessment, so that if you can demonstrate the effectiveness of it and the cost effectiveness of it, then it could be a reimbursable item.
Brett, your thoughts?
I think this is a very difficult question to answer. I guess in some narrow circumstances it might be a reimbursable item, but I think we're getting into the boundaries between medical interventions and social interventions and social prescribing. And, if you look at, for example, behavioural activation is an evidence-based treatment for depression, which I often mention to my patients, which is basically just doing things that make you feel better, either things that are pleasant in the moment and make you feel happier, or doing things that give you a sense of accomplishment or meaning. That could be anything. And do you fund the park run event that the person goes to on the Saturdays, or the walk on the beach, or the time they spend with their grandkids that gives them a sense of meaning? Look, it's so multifaceted. You can't fund all those things. So I think probably the answers here, while there might be some scope for MBS reimbursement of some things, I think a lot of it is around cultural expectations and changing the way we think about the boundaries of medicine and other parts of society.
I would personally love it if someone would fund me having walks on the beach. So let's get back to that one. But before we get too tied up in that, I am interested, Tim, to talk about your role. We didn't sort of really unpack what you do, but can you sort of give us a bit of a sense of what makes your role different in the practice that you work at, and whether maybe that is a model for you to toot your own horn? But is that a model where we actually have, well, I'll let you talk about what you do.
Yes, it is a model. So I work part-time for the Western Sydney Primary Health Network, and we have a program that funds consultant pharmacists to work in general practice as part of a multidisciplinary team in a patient-centred practice style. So the good news for the practice is I'm a free resource. I arrive at the practice, I've been paid for my time to be there, and I work with the practice population. So we talk to the doctors in the practice, the nurses, and identify a target audience. For some practices, that might be people with diabetes. It might be people at risk of diabetes or heart disease. And we identify those patients, and then we'll either bring them in to have a chat, talk about how they're going with their treatment, and then I help that patient along their journey of managing their condition. And in some cases, that's encouraging them to take the medication more regularly. But in all cases, it also involves what they can do to help manage their health as well. So the good news is I'm virtually free for the practice, and we can get some really good health outcomes with the patient. And it means that the GP is freer then to look after more urgent things that come into the practice at the time. So that's my role, and we've been running this for 7 years now, and we've been gradually expanding. We have a pharmacist in almost 10% of the practices in Western Sydney now, which is great. It's only part-time, but patients really love it. It's helpful for them, and it's helpful for the GPs because it frees up a lot of their time, and we feel like we're getting good health outcomes, but we do have to wait years to see the benefits because we're talking about preventing problems down the track.
Can you quantify, in terms of health outcomes, or even just in terms of reduced, perhaps unnecessary prescriptions? Is that something you've got data around?
We have data around that, and I can tell you that in the recommendations we make a lot more recommendations to reduce or cease medications than we do to increase or add medications. So it's, again, looking at, COPD is a great example where we will often have a patient who's been prescribed 3 or 4 inhalers. They probably only need one, and they may be not using them properly in the first place. So we can often rationalise their inhalers, make sure they're actually using them properly, and then also make sure that they're doing physical activity to help their lungs to work better, and then they get better value out of the inhaler, or they may not need it at all after a while. So we're reducing the number of prescriptions being written, and we're helping the patient get the best out of the drugs they've got, so then we don't have to escalate treatment.
From a public health perspective, yeah, go Alex.
I was just going to say, before everybody thinks I'm completely mad, that's exactly the sort of thing that I was thinking in terms of a rebatable item. I don't know if that's the best approach, but that there would be some kind of process for having a consultation that does exactly the kind of things that Tim's just been talking about. That could also include nature prescribing or social prescribing. So not that everybody would pay us, Tegan, to go walking on the beach, but that there would be some system consultation process, whether that's for pharmacists or nurse practitioners, could be for GPs, but I know GPs have got already so much to do. But that would make a system change, that would embed those kind of strategies into the system. Because from a public health point of view, to pick up your point, we can achieve so much saying to people as individuals, we want you to change your behaviour, but we know that the way to really change behaviour is to do it at a system level. So, for example, there's been a lot of talk about people shifting to lower animal product diets, which I think is great, but there's only so much you can achieve by doing that, asking individuals to change. And we know that there have been some studies that have looked at sort of relatively large community-based studies trying to get people to change their diet. They have small effect sizes, but more importantly, they target the individual consumer. And and they ignore all the other myriad actors that are involved globally in the production and distribution and use of food. So we need to figure out ways, and we really are, with climate change, facing the situation where we do have to think about transformational change. So we do have to start thinking about how we're going to change our systems to prioritise things like active transport, lower animal product diets, less prescribing, those kinds of things.
We've talked a lot about not prescribing or prescribing things that aren't medicines, but we probably do need to talk about sometimes people do need a medicine, sometimes there is a medicine that needs to be prescribed. So in terms of the practical ways of appropriate prescribing and sort of only what's needed to be done, Brett, how do you approach this in your practice when you've got a patient sitting in front of you?
It's a bit hard to answer that in the abstract. Did you have a particular type of medical problem in mind?
I think it's about, like, the thrust of this session is really about what can we do to drive appropriate prescribing in practice. And as much as we'd love to use lifestyle interventions or think about sort of societal change, sometimes you do have a patient that has asthma, for instance, where you need to sort of prescribe a medicine, but you want to be prescribing enough to do the job, but not sort of, how much is the environmental impact of what you're prescribing part of the decision that you're making? Maybe should it be more or less?
Okay, well, asthma is a good example. Well, as we said before, it begins with getting the diagnosis right, which is a little trickier in asthma because the obstruction is variable and can be missed on spirometry. But there's that. Then there's achieving good disease control. So regardless of what inhaler you're using, if you are using the right sort of medicines to get the disease under control, that preventers, usually inhaled corticosteroids, and you settle the asthma down, then they'll be reaching for many less puffs of their reliever. So hopefully overall medicine burden goes down and the environmental effects go down that way. Then there's the issue of choosing greener inhalers that don't pollute as much. And also getting the asthma prescribing in Australia. If you look at the guidelines, it says we probably should have quite a lot of people with asthma on a little bit of inhaled corticosteroids. And then you look at the dispensing data, and it says we've got a surprisingly large number of people with significant asthma symptoms who aren't taking a preventer at all. And then of the people who do take preventers, they tend to be at higher steroid doses than the guidelines would suggest are necessary. And people at those higher doses should probably be taking them regularly, but dispensing data suggests they're taking them in a very patchy way. So there's a great difference between the sort of prescribing, or at least dispensing, that we would predict from the evidence. We have challenges in improving things.
We are nearly out of time, but Tim, at the individual level or at the practice level, what do you think we could be doing to be more appropriately prescribing medicines?
I think the main thing is bringing the patient into the conversation. That patient-centeredness, for me, is the key to health outcomes. If we're talking to a patient about a condition that we're worried about or that the patient already has, and the fact that they have a role in, or they can have a role in managing that condition, I think the more we engage the patient in the conversation, the better the outcomes, and hopefully the less need to add medications to that, which complicates things even more. So I think for me, patient-centeredness and a team-based approach is really helpful. Sitting in a room with a doctor and a nurse and a dietitian or exercise physiologist and having a chat with the patient about the options, that really helps.
And finally, at the sort of systemic level or at the national level, what could we be doing?
I think the really good news is there are a lot of co-benefits from doing this. So everything that we do to reduce low-value care, and I'll go back to that slide that Kate just showed, there's a big chunk of the health sector that's low-value care, but reducing that is going to not only be good for patients, but also the evidence is really, really clear that when we do things to reduce overuse, we actually realise environmental co-benefits. So it's also going to reduce waste in the system. It's also going to reduce carbon emissions. And there's also potential for really significant cost savings. So it's actually a good news story. You know, I think, yes, the challenge is big. Yes, there's a lot to do, but there are a lot of benefits in doing it.
Alex, Tim, Brett, thank you so much for sharing your knowledge.
Pleasure.
Thanks for having us.
So we're going to turn now to the sustainability of antimicrobials, and I have with me someone who's uniquely qualified to talk about this. It's pharmacist Kristen Xenos. Welcome, Kristen.
Thank you very much.
So we've been getting questions from the audience. I want to put a few of these to you now, specifically around AMR. And the first one, someone's written in asking, is AMR the biggest threat to sustainability of medicines?
Well, I mean, I wouldn't say it's the biggest threat to sustainability of medicines, but it's a very significant one. Antibiotics, antimicrobials are one category of medicine, and the issues of applying to sustainability of medicines are really so much broader. It applies to all medicines, and that's for the supply chain and sustainability more broadly. Antimicrobials are a little bit unique in that when you take a medicine, generally, the impact of that medicine is located to you and yourself. Antimicrobials are a little bit different in that when somebody takes them, the impact has, for the broader community as well, not just for that individual. And the antimicrobials that we have, the current range of them, are an ongoing issue with safety and efficacy because of the issue of resistance. So our toolkit of antimicrobials is becoming more of an issue for ongoing efficacy.
So sustainability in the sense of not so much there is a planetary impact, but like actually is it a sustainable
approach,
class of medicines?
Definitely. Yeah. And we rely on them in so many ways for modern healthcare. So not just for, the person taking it for an infection, but we rely on them for things like chemotherapy, because people who have undergoing chemotherapy have a reduced immune system, more susceptible to infections, and we rely on antimicrobials to be able to prevent those. And other things like surgery as well. And if we don't have effective antimicrobials, then those things will be too risky really to subject patients to, because the risks of infections will be too great for them to continue on into the future. And what we'd done previously to combat that issue was rely on, we'll just develop some new antimicrobials to combat these new drugs. But the issue that is currently happening with developing new antimicrobials is it's really hard to do. It's expensive. They're usually intravenous, so have like a limited kind of scope of impact. And the bugs usually smarten up anyway to the new antimicrobials we develop.
So another question which kind of plays into that is someone who's asking for advice to consumers about what happens to discarded or out-of-date medications, especially antibiotics, and sort of how best to have that conversation with a consumer.
So ultimately, the key piece of advice for consumers is take all unused or unwanted medicines to a community pharmacy for safe disposal. And that's for heaps of reasons. We don't want to be throwing them into landfill because children can still get access to them and swallow them. But more specifically for antimicrobials is that when we dispose of them in landfill via general waste or down in the sink or down the toilet, that does enter the ecosystem and has an impact for antimicrobials. And we've got a really convenient solution that already exists. It's called the RUM project, and we'll hear a lot about that later on today, I believe. So return of unwanted medicines, and essentially they just incinerate the medicine at a really high temperature to make sure that it's done safely. And we know that the other thing is that antimicrobials, specifically certain agents, for example, ciprofloxacin, are really stable and very difficult to degrade, and we detect these drugs once they're discarded at really high levels in the ecosystem, so that further kind of provides evidence that it's an issue and we need to be throwing these away in a more appropriate manner.
Yeah, and just finally and briefly, like the third question from an audience member is, what are the steps to prevent antibiotic resistance?
It's a big question.
You got 1 minute.
Yeah, 1 minute. Okay, so I think we've heard a lot about prevention today, and that holds true for antimicrobial resistance as well. Preventing infections in the first place means we need to use less antimicrobials, things like vaccinations, hand hygiene, broader things like the social determinants of health as well. So clean water, housing, all those things impact how many infections we're dealing with. And then you're getting into like the basic tenets of antimicrobial stewardship. Don't take antibiotics for colds, flus, COVID-19. They don't work. Don't hold on to old leftover antibiotics, share them with family and friends thinking that you're doing them a service. Don't hold on to old repeats, just in case for future infections. Make sure you go to a doctor each time to make sure if it's appropriate. Other things we can do, diagnostics we've heard a lot about, so interrogating what is the exact cause of infection, and that can help minimise antimicrobials and the way that we use them, and trying to encourage oral medicine more than intravenous because that has less waste and less impact. And a couple of broader things as well, just to wrap up, in that we need to consider the impact of antimicrobials globally as well, because there are some countries that don't have the regulations that we have in Australia, meaning a person can walk in and request an antibiotic without really needing a prescription or to speak to a healthcare professional. And those people, we know that the more we use antibiotics, the more resistance develops, and those resistant infections can travel with them across the globe. So it becomes a problem for us locally, and the more we can do to support other countries in the world bolster their efforts for antimicrobial stewardship, the better.
Thanks so much, Kristen.
Thanks, Deacon.
We do need to leave it there because you guys need a lunch break. But while it's playing, grab your sandwich, bring it back to your desk because the lightning talks are here. And then after that, we'll have session 3, the carbon footprint of medicines. See you in a sec.